Да? Так, а что мне, убрать этот спонсируемый сеанс? Да. Так, все, я только оставляю этот. Угу. Спасибо большое. Все, я могу начинать, да? Спасибо большое. Но у меня пока они не отражаются почему-то в чате, кто есть. Хорошо. Спасибо большое, Дима. Давайте. Okay, guys, good morning. And I hope you'll write that you hear me very well. If not, then please write that you don't hear me very well. And I hope you will be collecting here to know a bit more about the immunological preparations that's supposed to be used in immunotherapy and immunoprophylaxis. Rabisha, hello, good morning, and I hope you hear me very well, right? Because you are the first visitor of my lecture. Thank you very much for coming. Okay, and Sahu, Sri Lakshmi, also thank you for coming. Okay, and I hope you all have coffee in front of you, and you may listen. And the topic of today's lecture, as I said, is immunotherapy and immunoprophylaxis. And that's what's supposed to be discussed today. But then, truly, we may need many lectures to discuss because this topic is really sophisticated, especially regarding vaccines development. So, and then there's really a doctor's topic because you may use these preparations to treat the patients and to prevent the diseases. And from the very beginning, I would like to announce that we decided in our department to develop one more lecture, and for you in the course of immunology, it will be the last lecture in this term. And this last lecture that I will read will be about coronavirus immunity. We will try to summarize at that lecture everything that we know now or the research community knows now about the immunity that can be or cannot be developed by new coronavirus, and also what are the list of the vaccine candidates by that moment. And that's important because as I knew, so we have more than 100 different types of vaccines against coronavirus that are now on different stages of their pre or clinical trials. Of course, I am not going to discuss all 100 types. So, but then we will give you an overview of the situation, how it occurs right now in the field of anti-coronavirus vaccine development. But then before you hear that, so of course you need to cover the basis first. That is the aim of our lecture today. So to introduce you to as many types of vaccines as possible and to take a look at the way of the immunotherapy development, and then next time maybe we will get more specific information about coronavirus immunity and coronavirus vaccine development. Okay, so I can start covering the basic of the immunotherapy and immunoprophylaxis. And in the very first slide here, you can see the main distinguishing feature of the vaccination, that is acquired artificial active immunization. And today we'll be talking about both passive and active, but then the active I consider really very important. And you can see here that what distinguishes active immunization. We've got the antigen or microbe, a part of the microbe, and we inject it into the body. And why this is called active? Because and this is just a repeating of how it happens in the body when the immune response is developed. So the antigen present in cells will meet these microbes and engulf them through their TLR, recognize them through their TLR and some other PRR receptors, engulf them, process them, run at least dendritic cell to the regional lymph node, and present it to T cells, and T cells will communicate with B cells that recognizes the same pathogen or part of it or killed pathogen already. And then they will develop immunity. So that's why we call it active, because as a result of this injection, we have body working on it. So to develop antibodies and to activate T cytotoxic lymphocytes that confine the humoral immunity and cell-mediated immunity, and to develop memory T or B cells. So then this is, I would like to repeat the basic scheme of the acquired artificial active immunization. But we discuss both, so I go ahead with this table and see here the immunopreparations we're supposed to study this week. These are antigen-independent preparations, immunosuppressants or immunostimulants. So immunostimuli or immunosuppressors may have something to do with antibodies, but not against some specific foreign antigens, but this rather against self antigens. But then we are not talking today about the antigen-independent preparations. We will be talking today about the antigen-dependent preparation. And out of the whole world of immunological preparations, we have just two vaccines that are antigens themselves. Of course, they are antigen-dependent preparation, and immune sera or immunoglobulins that are produced as a result of the encountering with the antigen. So these are two classes or large groups of immunological preparation that we use in antigen-dependent immunotherapy or immunoprophylaxis. And we start with the picture you know already, and that is the features and types of adaptive immunity. But we are not going to discuss the immunity today that is acquired naturally. We discuss neither active, natural immunity acquired by disease or acquired usually by the disease, or nor passive immunity, natural immunity that is transmitted from mother to child. We concentrate today on the artificially acquired immunity. So it is intendedly used to develop passive or active immunization. And as we discussed in the previous slide, that Active immunization is connected with antigens introduced into the body as a vaccine, and body will be raised up and develop antibodies and specialized and lymphocytes itself. Or we also need to mention the passive immunity. When someone else performed or preformed antibodies will be injected into the body. So then, what is the aim of immunization? By the way, the aim can be seen, or the goal of immunization can look differently regarding different levels. So, if we take a look at the organism level, immune response or immunization or immunotherapy will block the spread of bacteria within the body, or will neutralize the toxin that can cause harm in a body, or may neutralize virus, and then the virus will not be able to bind with the target cell through the particular receptor and enter the cell and to reach the target organ, so it won't be able to replicate. So these are the goals of the immunization or vaccination or immunotherapy that are seen on the organism level. But then if we are talking about country or community, so then the goal is different. The goal is to, you can see here, to stop the spread of the infection among the community members. And this can be done by reducing the number of susceptible individuals to this infection, or susceptible to this infection, right? So, and you might heard this very often right now, because in all countries, Europe, the United States, Russia, we are all worrying now about the development of the herd immunity, so that can be seen on national or international level. We want some people when they are infected to develop antibodies, but that occurs right now naturally. But then we want to prepare a vaccine to make as many people non-susceptible to the disease as possible. And when the disease is new, like new influenza virus that occurs in 2009, or new coronavirus that occurs first in 2002, that was SARS, and now in 2019 it was a COVID new one, right? So we are worrying that all people are susceptible equally in the whole world. So that's why the spreading of the disease can be going very fast. So, but then if you make this herd immunity in the population, and that's the goal for immunization, then the microbe won't find the susceptible individuals. It won't ride from one person to another one with the extra speed. So then it won't spread so quickly. Of course, some people can be infected, but not that many. So that's why this goal that is seen in national or international level is of utmost importance. And then to evaluate what had been done since the vaccines had been developed and the immunization had been developed. So what we reached by that moment, for example, we managed to decrease dramatically the symptoms, the appearing of the cases, and the appearing of the symptoms of quite a lot of diseases. Pertussis, that is whooping cough, diphtheria, tetanus. We also succeed in spread in stopping, controlling of spreading the diseases such as measles, mumps, rubella. We'll talk a little bit more about measles regarding anti-vax movement today. So, and then what is really is recognized as the really great deal of the WHO is the elimination of the smallpox in the whole world. And by now, the poliomyelitis also is eliminated from the Western world, and this I'm really sorry about, especially those who live in India and somewhere in Africa, because there still we fail to do this, because the poliovirus may reside for a very long while in open, fresh, or salt waters. So then, unfortunately, the poliovirus still could be isolated, wild types, not vaccinal strain, but wild types from some environmental sources in some other countries. India, not so far ago, I've heard that it can be isolated in former Soviet Union republics, like Kazakhstan, Uzbekistan. So, from time to time, we always have some outbreaks. So, what does it mean? Those bad bugs, microbes, they don't disappear. So, if we stop the vaccination program, then they will reappear again. They never gone away forever. So that is the problem with the pathogenic bacteria and viruses. They can hide somewhere in nature. So I hope we eliminate smallpox forever, because it cannot be found in animals. The humans are the only hosts of it. You know about this because you have passed microbiology already, so we go ahead. And regarding the intended artificial immunization, we have two types, active and passive, and they have different, by the way, goals. The goal of active immunization is the immune response and immunological memory developed in response to challenge with the antigen that is immunogenic. While the goal of the passive immunization is rather give rapid but temporary protection to prevent the development of the disease. And by the way, just you know this, that sometimes even one type of immunization is not enough. We may perform two, active and passive combined. But I found a very nice picture that will really demonstrate the goals and the and the dynamic of the active and passive immunization. And you see here the passive is shown green, and the active immunization is shown dark red. So, and with time, the number of antibodies or the antibody concentration when we develop passive immunization will be decreasing. See? So as soon as we inject the antibodies produced by someone else will work for a while and then drop dramatically. And you're supposed to know that they would work within 3 to 4 weeks, not more. Because you still remember maybe some issues of biochemistry, that immunoglobulins will be metabolized within around a month. So that's why we give rapid protection, because you can see at the moment zero when we inject this preparation, the concentration of the immunoglobulins will be highest. Then with the time around a month, they decrease and disappeared completely. Right? That is the dynamic of the occurrence of antibodies in the body within the passive immunization. That's the clue for understanding what can we use it for. Of course, mainly for treatment, or mainly when we think the microbe is already in the body or somewhere nearby. So then we give maximum protection at the very beginning. And this is when it is urgent to fight with the microbe. When it is not very urgent, so then we have, we have time to develop active immunization. And you can see here that it takes time. And the initial at the day of the antigen injection, so the initial level is 0. So the production of antibodies or T cytotoxic activation of T cytotoxic lymphocytes, it takes time. So it will go even like this a bit. But then, so we demonstrate here how usually the cause of vaccination occurs. Usually the modern vaccines should be repeated several times. So then this is initial injection. The level of antibodies will be high already, but not high enough to protect against the disease. Then, within several months or most probably years, we give some more so-called booster doses of the same vaccine. So these booster doses will increase the number of the memory cells, but also increase the number of producing antibodies. But then after the last boost, so we may have the highest level of antibodies. And what is a good thing about the active immunization? This level of antibodies may stay after some vaccinations for the rest of the life. Or, generally saying, the active immunization cause long-lasting or lifelong immunity, while the passive immunization causes short-term immunity. And that is the very important difference between passive and active immunization. So when we inject antibodies for passive immunization, we account on just antibodies, their presence, and we give them time around 2-3 weeks to neutralize the virus, to neutralize the toxin, to opsonize bacteria, to cause the elimination of bacteria, and so on. When it won't work within 3 weeks, then we have to repeat the injection. But then when we perform active immunization, we account not only on the level of antibodies, and maybe not on it exactly, but we account on the number of the memory cells that will be developed within the initial injections and booster doses of the antigens. So then, because we start with passive immunization, and we just discussed some features of passive immunization and preparations that can be used for it. So then, specifically, what do we use the passive immunization for? The very important thing for you as future doctors, so we may use it after a known exposure to some dangerous bacteria or viruses. Most commonly, we are thinking about viruses. We are thinking about hepatitis B virus. So due to the exposure to HBV contaminated blood. But thank God, now I hope you are all vaccinated with hepatitis B. So HBV can be replaced with HIV. So because still we don't have any vaccination, even promising results in vaccination really in real life. So that's why maybe it could help in that, or any exposure to any pathogen. Then This passive immunization can be used to protect immunosuppressed patients, those that cannot produce antibodies themselves. And there are many reasons why they cannot do this. Anti-tumor or anti-cancer therapy, or organ transplantation, and the number of those patients are rising right now. Those who need transplantation and in whose bodies it occurred, so they are under immunosuppressive therapy. They need this. So then, another reason. So if we have already an infection ongoing in the body, then within the initial stage of the disease, we may also use passive immunization, and we may decrease the severity of the disease or ameliorate the symptoms of the ongoing disease. And this is very important also, because as we inject antibodies, we may prevent, for example, in newborn babies infected with chickenpox, we can prevent the very severe, or measles, prevent very severe complications of those diseases. For example, you know that measles may develop very strong effects if they enter the nerve system of the fetus. So then, if we inject, or the very small baby, if we inject the antibodies, so we may prevent the microbe to enter the target organs, and while it is in the blood yet, so antibodies may neutralize it. And also it's important with the artificial passive immunization to block the action of the bacterial toxins. And for this, that's really very wide use of immunoglobulins or immune serum, because still it is very important to perform passive immunization on those who had been exposed to tetanus, Clostridium botulinum toxin, or diphtheria toxin. So now, I hope you know already, and you will demonstrate it when you will have final class and description of the immunological preparations. So you will tell that the sources of antibodies are just two right now: humans or animals. What kind of humans can be source of the antibodies? We call them collectively as seropositive individuals or donors. And the preparation taken from donors is called homologous, because from the same species. But then, this is important also to understand who may serve as donors. So, of course, those who survived the disease or recovered individuals or patients recovered from the disease. But please know that we never take any products from the patients who are suffering from the disease right now. We may take antibodies from those who completely recovered already. Because the first question or the first answer students usually give about the source of antibodies, these are patients. No, my dears. The patients cannot serve as a source of the antibodies. They need antibodies themselves. So that's why we call them seropositive individuals. Those who recovered from the disease, or those who had been vaccinated once, developed very good level of antibodies, and now they can act as donors to donate blood serum with particular type of antibodies. Then the second source of the antibodies are animals. But then, to develop these antibodies, the animal should be first hyperimmunized with the antigens. So that's you write in your preparation description. Hyperimmunized animals, but then you should understand what kind of antigen is used. So if we want to develop immunity against toxins, so then the toxin supposed to be injected. Not exactly the toxin, but something that has antigenicity and immunogenicity, and for the immune system looks like a toxin. You know already that this is anatoxin or toxoid. So, but then, a few decades ago, the only horses usually were the sources of the antibodies. But the things change with time, so today we discuss what other animals can be source of antibodies for us right now. But traditionally, and we go for that. So this is quite old picture. And this old picture shows how the antidiphtherial serum had been produced. But by the way, right now nothing changed dramatically very much. Of course, the use of animal sera drops dramatically. And we have very few situations when we really use anti serum taken from animals or heterologous serum. So, and you see that even this poor horse is covered, so to get as sterile conditions or as aseptic conditions as possible. Uh, of course, but then this is not a poor horse, because we're supposed to feed it very well and take care of it, because once we boost the horse with the antigen of interest, it's still producing antibodies, and we perform hyperimmunization, and from time to time we collect blood. But then we keep the animal alive usually. But then what is the problem with heterologous animal serum used in humans? So of course you know already that we may have hypersensitivity reactions of type 1 and 2 caused by heterologous animal serum. And usually to prevent this reaction, we may perform acute desensitization. It means we may give the animal serum portion by portion with 10-15 intervals. And we use intramuscular injection but not intravenous injection to prevent the platelet segregation, complement activation, and type 1 hypersensitivity reaction and type 3 serum sickness. So these precautions are done. So I think by now the degree of this horse serum use is really very low. So it is really very limited, mainly to by using the antidiphtherial serum and antibotulinum serum. So then I think in a lot of other cases, this serum can be replaced with better homologous preparations taken from donors, or highly purified serum where we extract immunoglobulins if we take animal serum. So the animal high titer immunoglobulins also can be used in treatment. And of course, this is much better than to use heterologous animal whole serum, because the preparations of the immunoglobulins much more purified to compare with the whole serum. They will lack a lot of the ballast albumin and other proteins that may cause hypersensitization. So it is much better to use the heterologous preparation like high titer immunoglobulin. That's also possible. So, and these are the list of the diseases. where we really quite often need the use of the passive immunization with antibodies. And these three diseases are connected with the um, need of the toxin neutralization with antibodies. All three diseases originate just from toxin appearance, right? And you can see here that usually for botulism and diphtheria, this is taken from horses or produced in horses, right? So hyperimmunized with the toxoids. And for tetanus, we may have tetanus immunoglobulins and high titer immunoglobulins taken from both animals and humans. And collectively, those antibodies that we inject are called antitoxins, and they are developed in response to toxoid injection into the animal or into the human. My dears, don't confuse between antitoxins and toxoids or anatoxins. Antitoxins are antibodies, and toxoids or anatoxins are antigens. Okay, so then the high titer of immunoglobulins against some viruses are also quite often can be used, but then they usually taken from humans, and that's about the hepatitis B immunoglobulins and varicella immunoglobulins. But then for rabies, regarding rabies disease, so the immunoglobulins used are taken from both animals or humans. And please pay attention that against the rabies, the only high titer purified immunoglobulins are used, not just serum. And I hope you remember that to prevent the virus spreading through the nerve system, we need to have in the body really very high level of antibodies. And maybe there's not enough just serum, so that's why we use mostly high titer of anti-rabies immunoglobulins. Okay, we go ahead with the preparation that is also important. Okay. So the preparation is called human serum gamma globulin or pooled gamma globulin. And how it is performed. So we take serum from around 50 to 60 thousands, right? So from many people. So then, what we expect to have there in this preparation? Normal repertoire of antibodies that happens in your blood and in mine blood, right? So these are antibodies against most common human infections. So, and so for your information, those individuals are not really freshly immunized with any specific antigen. So they haven't underwent any hyperimmunization or vaccination right now. So this is just middle level of antibodies that may be found in the organism of any healthy donor, any healthy individual. But then, if we take a look at this repertoire, so then we may have there antibodies against chickenpox, antibodies against measles, antibodies against hepatitis A and B, antibodies against diphtheria or tetanus toxins, and so on. So these are the antibodies that may protect an immunocompromised individual, and this mainly for them this is important. So from the common human infectious diseases. And you can see here that usually these pooled plasma immunoglobulins are taken from donors, not freshly immunized, but just the pooled donors plasma. But by the way, this is one very important advantage of this preparation. So when we perform plasmapheresis and produce plasma, then we can use it as intravenous drugs. And by the way, this in the Western world, it is called replacement therapy. And by the way, now it is really very important, because can you compare the number of immunocompressed and immunocompromised individuals that occurred in the human population 50 years ago, 5 decades or 4 decades ago, and right now? Don't you forget about HIV. So it makes so many people immunocompressed, but then they still need to be protected against all those typical everyday human infections. And by the way, those even not so severe pathogens like varicella zoster virus may cause very severe complications and very severe states in immunocompressed individuals. So that's why the importance of this intravenous immunoglobulin therapy is now really very important when we may perform injection through the intravenously. But then there's a lot of people are working on the preparations to improve these preparations of the plasma for intravenous use, because they really are very important. This is a very important preparation right now. But then this pooled plasma also may help not to exactly the immunocompromised individuals, but then it may be used for premature babies, for example, or children that live not in very good health conditions and social conditions that may have delay in the antibody production, and this is children with malnutrition, those who had been exposed to hepatitis A or B, and then we may perform this therapy to give them already produced antibodies on intermediate level and so on. So that's how can we use it. And the third group of preparation is different. So, and initially it was preparation produced in mice, and you know these monoclonal antibodies preparations. But now we have a variety of those monoclonal immunoglobulins, and we are going to talk about it. And now, since the hybridoma technique had been developed, the monoclonal antibodies out of hybridoma start to be very important tool, and you know already that this is a very important tool in diagnosis and also in the assessment of the immune status of the body, the assessment of the autoimmune and inflammatory diseases. So this is a very good tool in diagnosis. But apart from the diagnosis, now this is mainly one of the most common type of preparations used against cancer and against so-called inflammatory and autoimmune diseases, for example, systemic lupus erythematosus and others, right? So, but also now monoclonal antibodies, we believe, can be used against some viral, bacterial infections. So that was not typical from the very beginning. Since 1980, the monoclonal antibodies therapy had been really very expensive, and it had been used mainly against very severe disease like cancer. But now the technology of the antibodies production getting to be less, really very complex, but not so expensive, because the scale of the monoclonal antibody production increased dramatically, and it reduces a little bit at least the price, so the monoclonal antibodies are really available on the market as a tool for treatment of a lot of diseases, but priority is given to the anti-cancer treatment, of course. So, and then one of the variant of the monoclonal antibodies, there's the immunotoxin, that when antibodies, monoclonal antibodies, are conjugated with the some toxic molecule that can be, by the way, radio-labeled antibody, and that is used in cancer therapy, or toxin-labeled and monoclonal antibody. So then the monoclonal antibody, when bound to the target cell, it can cause the death of this cell, so to prevent the tumor development or the virus multiplication or whatever else. So then, few words about the evolution of immunoglobulin therapy. Apart from what we said about the human pooled plasma globulins, and they can be used intravenously. Prior to 2014, usually, mainly we have used animal or reconvalescent polyclonal antibodies for treatment of infectious disease. But by the way, so if we want to take a look at the demonstration of how the evolution happens, we may take Ebola hemorrhagic fever as an example of the disease. So, and usually the common preparation that had been used since 1890 something is the polyclonal immunoglobulins that occur in the blood of hyperimmunized human, horse or primates or whatever, right? So, and we may have three types of the preparations: whole blood, plasma, and purified immunoglobulins. So the whole blood, that's not about immunoglobulins, it's not used for this, but then plasma is used, can be used, and the purified immunoglobulins, what we said already, right? And then can be used, and before 2014, these antibodies could be recognized as a very good treatment against the Ebola hemorrhagic fever. But the problem was in the limited number of those people who survived natural infection, and also limitations that the use of animal preparation give. And then in 2014-2016, Ebola virus outbreak in West Africa was really the most severe within the whole history of this disease since 1972. So, and it was the deadliest in the history of the Ebola disease. So that's why the need was understood over the so was really necessary the preparations that can be used urgently and that can be used, by the way, intravenously. So they developed the very special technique when the monoclonal antibodies can be produced in mouse or later on in humans, and the antibodies extracted from hybridoma, so genetically engineered to replace the mouse component from the antibody, and replaced by the human component in these monoclonal antibodies. And then they will be transferred to the tobacco plants or in the bioreactor. So, and the result was the purified monoclonal antibodies that can be used intravenously against the Ebola virus. So, and then we now take a look at the evolution of the monoclonal antibodies. And this is schematic overview of the monoclonal antibody, so-called humanization. So, and then initially, you know that hybridoma technique had been done using the mouse or murine myeloma cells to fuse with the B cells taken from the spleen of immunized mice. So they were completely mouse antibodies. And here you can see the dynamic of the immunogenicity of these antibodies. What does it mean? That if those mouse antibodies had been injected into the human body, they will be quite highly immunogenic for the body. They had so-called immunogenicity against, or we recognize these antibodies as immunogenic and could develop immunity against these antibodies. That is really the problem with the heterologous monoclonal antibodies. But then it was possible to develop so-called, now we call them, chimeric antibodies. You can see here that the C constant domains 1, 2, 3 of the heavy chain and one domain of the light. That's one light domain on the constant domain of the light chains and 3 constant domains of the heavy chains had been replaced with the human constant domains genetically. So then the only tips of the antibodies, so the Fab fragments that recognize the antigen and they are specific to the antigen, had been left from the mice. Then we go ahead. So we've got so-called humanized antibodies, and they only include the very hypervariable segments of murine origin, and the rest is produced from humans or have the amino acid sequences from the humans. And finally, we get it in humans. So we may use the whole spectrum of these antibodies, and of course, the less components of the mouse antibodies we have there, the less immunogenicity do we have. See here, you can see now the antibody structure of these monoclonal antibodies, the basic structure of these monoclonal antibodies, and you can see in color the differences between the completely green murine antibodies, and usually if you take a look at the name of these antibodies, it should end with MOMAB, right? So that means that are completely murine, omalizumab. Oh no, zumab is humanized already, sorry. Then we have a whole molecule of the taken from the animal. So then the chimeric antibodies, the name of the therapeutic preparation should end with ximab. If you see this, these are chimeric antibodies, and the variable regions of the light and heavy chains are left from the mouse immunoglobulins, and the rest is human, right? And then you can see humanized monoclonal antibodies, where you can see the only green bands. So these are hypervariable regions that themselves will react with the antigen. So, and this is only of the murine origin, is the rest of the human origin. This is called with zoo, and the known and used widely against asthma omalizumab. These are partially humanized antibodies. And then finally we reach the ideal picture, right? That we may have human, and they are ends with umab antibodies. They are of human monoclonal antibodies. And here you can see the different types of the antibodies. Mainly C ends with momab, right? Momab, there's a murine. Zumab, there's a chimeric already. Humanized already with Zumab, right? These are Zumab, also Xi, also possible. So these are antibodies, but then that's mainly, as I said, they are used against the in anti-tumor therapy, and usually they bind with the very important antigens. For example, in alemtuzumab, right? So there's again the chronic lymphocytic leukemia. They binds with the 52 antigen which is found on lymphocytes, including leukemia cells, right? So, and the antibody causes a first dose cytokine release syndrome, and the tumor necrosis factor, IL-6, interferon gamma will be produced as a result of it, and ADCC will be activated. And quite a lot of preparations are against the tumors. And very well known right now, very common, Beva Kizumab, there's Avastin, the trademark, is the monoclonal antibody that targets a protein that called vascular growth factor, epithelial growth factor, that affects the tumor of the blood vessels growth, right? So, and that's really very common in the treatment of the tumor diseases, okay? And this is the short example, or short table, small table, that may mention some, but this now we have really a lot of them. And then this is an example of conjugated monoclonal antibodies. Zevalin, this is the trademark of the ibritumumab tioxetan, so I cannot even pronounce it. This example to radio-labeled antibodies that can be used in the treatment, and this is Zevalin, right? See here, they target CD20, and that is the CD marker of the matured B lymphocytes. And the antibodies deliver their active molecule directly to the cancerous cell and not any other cell, right? And it is used really widely right now against some types of non-Hodgkin's lymphoma, B-cell lymphomas, right? So I think you understand that this mechanism is also very important, and now it come to truth, not really some ideas. So it is used in the anti-tumor therapy. So then, okay, I think we've seen it already. So we cover the goals, and now I think there's enough for use of the immunoglobulins. But then when in the next lecture we will touch how it is used now, and whether it is used, whether it is effective against coronavirus itself or not. So we come up to active immunization, and it is used to induce immune response and immunological memory, and that is the very important. And without any doubts, the body should be challenged with the antigen or immunogen, because it needs to, in a form that will be able to evoke the immune response. You know that some antigens cannot do this. So we have to design vaccine so the target antigen will be the immunogenic also, not just antigenic. And that is really important because the more purified antigen we have, the smaller it is, the less antigenic determinants we have there, and the less immunity can be developed. So it is known already that large, and you know this from the antigen's properties and description of the determinants of immunogenicity, that the small oligovalent antigens are not highly immunogenic. They are safe. They don't have any extra molecules, but they are lower pure immunogenic. So that is the problem, one of the crucial problem of the active immunization or vaccination. The more we purify the target antigen, the less immunity it develops. So we have to work hard with the system of this antigen delivery. This is one of the ways of the vaccine improvement. And then we have to increase the immunogenicity of this antigen. So in this respect, regarding this point, the old vaccines were much more immunogenic than a very new one. So, but then we try hard to remodeling or design the vaccine so to make them as immunogenic as possible. So usually we use active immunization when we take microbe or some antigens or some toxins of this microbe, and we make vaccine out of it, and we make vaccine or we use vaccines for specific prevention or prophylaxis of the disease. Specific, it means this preparation will act to prevent only this type of the disease, but not the others. So vaccination against H1N1 influenza virus, helpless against coronavirus, right? It doesn't mean how you had been vaccinated before, with what antigens. You haven't been vaccinated with this exactly antigen, so you are not protected against it. That is very high specificity of the process. So that's why it is called specific immunization or vaccination, or specific prophylaxis. So, and of course it is artificial active immunization. So, and sometimes we may get again infected naturally, but we are not discussing it because this is the natural active immunization. We concentrate on artificial active immunization. I won't spend our time to repeat this story about the Edward Jenner, not because I don't appreciate this, but because you know it by heart, I hope. If you don't know it by heart, so ask Dr. Google. But then I just want to mention that this is the first, maybe very well recorded experiment on human being, because Edward Jenner first immunized the boy with the cowpox, and then in front of the whole city he challenged him with the true variola, highly dangerous variola virus, to prove that the boy is protected already by previous vaccination. So we go ahead with it, and we can see here the last one of the very last cases in Ethiopia in 1978, if I'm not mistaken. So, and then it was one of the last cases, and after that, since 1980, none of the cases of smallpox had been found anywhere. Sometimes it can be confused with the monkeypox, and there were some cases when monkeypox, when the animals had been carried in the baggage department or luggage department together, for example, monkeys and dogs, pets of some passengers. But then the dogs had been infected with monkeypox, and then the owners of these dogs had been infected with monkeypox from dogs. So that happened from time to time in the USA, in the UK, and some other countries that have the traffic of the animals. So really very high, right? So, but then that's not the same. It may at initial stages resemble the smallpox, but it is not smallpox, it is a monkeypox. So then we think that smallpox really is eradicated from the human population, and you know already that one of the point why it had been possible, that very good vaccine had been developed out of vaccinia virus. Okay, we go ahead. And you have to remember, because you have passed microbiology exam, you have to remember that Louis Pasteur introduced this term and did several types of vaccines. And basically, the whole spectrum of vaccines can be divided broadly into two groups: live vaccines and not live vaccines. But by the way, you saw these not live vaccines, they are live vaccines, but then here we have DNA, or I would add RNA and so on. So it means, except for the live vaccines and dead vaccines, we have something in between, but then we discuss it a bit later on. So, and this is the most important, there is a crucial difference between these two types of vaccines that reflects really the advantages and disadvantages of using these vaccines. This one that is live, that is good in a lot of considerations. Why? Because it mimics the natural infection. Then the very low dose usually is needed for vaccination with live vaccine. Why? Because as soon as we inject it into the body, it usually multiplies. So the amount of antigens increase. So we have permanent immunization of the body. So then the immune response usually is very high. Then when we are dealing with inactivated vaccine, we don't have this effect. Once we inject the particular dose of this antigen inside the body, it won't propagate, it won't multiply. So that's why we have what we injected. So that's why these vaccines can be injected, or usually injected, many times. We perform initial immunization, then several booster doses should be given, and that is considered as one course immunization, and it should be repeated several times within the life, right? And that really difficult, right? Because we cannot develop immunity very quickly, quite quickly, right? We need a lot of booster doses. While the one single injection of live vaccine may protect a person for several years, and if it is repeated, then for the rest of the life. So that's why this is a really great advantage of live vaccine. But then we have some other advantages, but I am not going to discuss them all. I think you know, I just want to underline what is most important. And then we have a really disadvantage of live vaccine. And disadvantage is that if something goes wrong, they may multiply, not in the site where they're supposed to not multiply, for example on the tip of the nose, but then may go deeper, enter the bloodstream, and reach the target organ. And that may happen usually when the immunocompromised individuals can be immunized with the live vaccine. So it is strongly contradicted. And usually the vaccination with live vaccine is not recommended to pregnant women, and it is not recommended for very small babies. So we try not to give them live vaccines, but excluding BCG, I think, because it is given to babies, but not to immature babies. Also, we have a long list of contraindications. So that's the problem. So that these vaccines cannot be given to everyone. And by the way, right now, we have a lot of, we'll talk about it, about anti-vax movement. So a lot of people hesitate to use especially live vaccines. So, and that is the problem, because they are really very good and give very good immunity. Of course, regarding the safety considerations, the inactivated vaccines are much better. So they are much safer. Even if they will be repeated several times, they never cause any infection within the recipient body. So that is the great advantage of an activated vaccine. So, but then, except for safety, that is very important property of vaccine. They should be safe for the recipients. Then some more very important consideration exist: immunogenicity and protectiveness. So, and then the problem with some diseases, that we don't see any correlation in the immunogenicity and protectiveness. So against HIV, a lot of vaccines tried and then used to produce very good immunity, very high level of antibodies, or very good sensibilization of T cytotoxic lymphocytes. They are ready to work. They are up in the body. But then, when it comes to protection, this immunity doesn't give protection. That is the problem. That vaccines are, or they can be safe, immunogenic, but not protective. So that's why so long way is needed to produce good, safe, immunogenic, but then vaccine that may protect the person from the disease. And these three considerations in vaccine development make it not so easy for some diseases to produce proper vaccination. So then, if we take a look at the types of vaccines, of live vaccines, because we start with them, and historically, I think they were first vaccines developed. So, the organism is treated so to have limited ability to cause disease or to multiply in the body. It can be it should be absolutely avirulent or attenuated or weakened, you know this. So we have discussed a bit, right? So live vaccines can be of several types. So the most common is live attenuated vaccine, where the wild type of the bacteria or virus had been subcultured in non-optimal conditions. Sometimes temperature is not optimal, sometimes the hosts are not optimal, or the culture medium is not optimal. But then this non-optimal condition allow bacteria or virus to mutate, to some of the microbes adapt to the growing in not optimal conditions, and we just select the mutants that are weaker as the pathogens than the wild type. Then we have second type, that are virulent microorganisms from other species that share the antigenic determinants with human pathogenic, and that's usually viruses, but also possibly bacteria, but then they don't cause the disease by themselves. And this is called divergent vaccines. And the third type, this is a quite new one, but truly now this come to be very common. So hybrid vaccines that can be used for those pathogens that cannot properly attenuate it, or it's difficult to produce the proteins of this virus. For example, it cannot be propagated in vitro outside the human or animal body, so it cannot be cultured in cells. So then we may use the hybrid vaccines. So now a few words. Yeah, we have discussed this. I think we don't need to discuss it anymore, the live attenuated vaccine. Okay, just example. For example, the mutant rabies virus can replicate at the introduction site, but cannot develop the neurogenicity, for example. Or poliovirus, the vaccinal strain can replicate in the gut, but cannot reach the immune system as wild type does. So we select the mutants that cannot cause really the disease. But then Louis Pasteur used the very long way of attenuation, right? So right now it can be done very quickly with the help of genetic engineering, or developing the mutation that inactivate or delete a virulent gene instead of randomly attenuate for many years. For example, I hope you remember that in BCG vaccine, Calmette and Guerin bacilli had been attenuated for 13 years. Can you imagine? 13 years of attenuation. And now it can be done within the few months by genetic engineering. So, and the example of attenuated vaccines are Bacillus anthracis as the example of the antibacterial vaccine, and measles, mumps, rubella, but also influenza vaccine for the temperature, for the viral vaccine, sorry. And, okay. These are examples of live vaccines. And I would like to tell a few words about measles, because you know that quite often right now we may see some outbreaks in the countries that claim that they never had measles again, right? So, but then you can see here the moment when the vaccine had been introduced in the human population, and here it happens. I think it is a United Kingdom or USA. I don't know. Okay, so but then can you see how dramatically the measles cases, and here you can see the measles deaths. So it was very high per thousand of human population, and then it drops dramatically, so from time to time. So but then we had outbreak somewhere here, right? And here you can see the sign or the rash typical for the measles case, right? So then, and it appears that the only vaccination allowed us to control this infection. And that is demonstration of the herd immunity, right? So if we have poor vaccine coverage or vaccination coverage, if we have a person who shed the microbe, then here the community is protected, so nobody will be infected, most probably. But then the the cover of vaccination is poor, the only these blue are vaccinated. So then there is a place for transmitting case to transmit the disease. So that's why we so care about the herd immunity and the good cover of vaccination. And it is known, for example, for measles as a disease, the 95% of coverage is enough in vaccination to prevent the transmitting of the cases. If less, then it will be transmitted. And now I would like to mention, so give you a few slides about the movement, and this is a regress in medicine, right? The movement that against vaccination, it is called anti-vax or anti-vaccination movement. A regression is modern medicine. So we have a lot of people that hesitate to perform vaccination, to practice vaccination of their children and of themselves. So a bit about the history of this movement. This is a recent trend, but then mainly it occurs in Western countries, but also in Russia. I've heard some, but this is not that dangerous, I think. So in those Western countries, parents refuse vaccination of their children due to numerous reasons and fears. By the way, those reasons quite often, and it appears not so far ago, a year ago in 2019 in the USA, that religious traditions also can be very dangerous reason to stop vaccination that occur in some communities in the United States. So while opposition to vaccines is as old as vaccines themselves, because had been always people who've developed fears against the vaccination, there has been a recent surge in the opposition to vaccine in general, specifically against measles, mumps, and rubella, and that's because all three here are live attenuated vaccines. So theoretically that they can multiply in the body. But where is the source of current fresh disease activation of this movement? This is a person. So the trigger for what could we become a worldwide controversy over vaccine safety was a single scientific research paper. It was not really the research paper, it was really fake. So, but then it had been published in very good medical journal. That's Lancet, has very high rating among the research journals. In February 1998, so, and it had been written by 41-year-old academic researcher Andrew Wakefield and co-authors by a dozen associates. And it had been reported there about 12 anonymous children with apparent brain disorders who had been admitted to pediatric unit and the Royal Free Hospital in Hampstead, North London, UK, between around July 1996. And the prime cause of the alarm was finding in the paper claiming that the parents of 2/3 of these 12 children blamed MMR for the sudden onset, or what later had been described as the regressive autism. But then, since that time, a lot of research works had been developed, and those really scientific research work show there's no absolutely connection between any type of this autism and the MMR development. But then this paper that then considered, and by the way, this person later on confessed that it was fake. and he is taken back the medical license. But then still, these movements start to be really very powerful, especially in the United States, as a final country of democracy, So the democracy, they think, is when you may do whatever you want. But that's not true. You have responsibility as a part of the community. So I think you heard about the new amendment that had been approved in the United States regarding the measles outbreaks. And it was stated that children that had not been vaccinated against measles, mumps, or rubella, out of these three, the measles is the most important. They are not allowed to visit public places. All those daycare centers for babies, all those, like Fozzy and Meganom, all those centers. So kindergarten schools, because they really appear as a threat for other people and for other children. So you should not support this movement, my dears, because you're going to be doctors. Okay, we go ahead with live vaccines. And the divergent vaccines, also common now. For example, the cowpox vaccine initially was divergent vaccine. And now the divergent vaccine is the rotavirus vaccine, because it consists of bovine or simian rotavirus that is not highly pathogenic for humans but can be used as den antigens. And also adenovirus vaccine may consist of a viral strain used for administration in the respiratory tract. So you can see those who visited microbiome lecture, they remember this slide. So because there's a comparatively new vaccine for babies' vaccination against rotavirus, right? And 2 rotavirus vaccines are currently licensed by FDA in infants, and usually they consist of combination of human and bovine viruses. So then live vector vaccine, that's a quite new one. So we take safe virus and the adenovirus or vaccinia virus or respiratory syncytial virus can be also used as safe and effective and reliable vector. And then the genes of interest are incorporated into this vaccinal vector. And when this virus replicates in the body, then it produces not the only self-proteins, but also proteins of interest. And vaccinia, herpes simplex virus, adenovirus had been used right now as experimental vaccines. For example, these techniques usually are used against those diseases where it's really difficult to develop vaccination. So, and one of those is dengue virus infection. Do you remember that it has 4 serotypes from 1 to 4, right? And the vaccine should contain the glycoproteins or surface envelope proteins of all 4 serotypes. Otherwise, the vaccination may cause the development of the most severe infection in the absence of neutralizing antibody, but presence of anti-dengue not neutralizing antibodies. So then, if we take, and for the vaccine, the yellow fever vaccinal strain had been used, and the yellow fever genes had been replaced with the code protein genes of dengue virus wild type, and here they are inserted. So then we have the chimeric clonal DNA, and then it had been transcribed to RNA and inserted because yellow fever, as you I hope remember. Oh, what is this? Okay, so if you remember, is RNA virus. So then we can grow virus in culture, and then it will replicate engine taken from the yellow fever vaccinal strain. So this is the type of vaccine that is very promising again dengue, and it is called Dengvaxia. Now a few words about the poliomyelitis. Again, there was the only way to stop spreading of this disease, and you can see here that this is previous number of the cases of the per year of so over the this World Health Organization in the world, right? And that's how it comes when the vaccination had been developed completely. And you can see that vaccination against polio can be performed in two ways. Oral way, this is an oral polio vaccine, and inactivated vaccine that is used intramuscularly or subcutaneously. So then, if we are talking about live bacterial vaccines, we have still quite few of them. Do you remember typhoral vaccine? This is oral vaccine against Salmonella typhi. Then the second one, very well known, is BCG, and very contradictive vaccine. But have you heard? Okay, no, then we discuss it next time when we discuss coronavirus. But because the Western world think that BCG vaccination influence somehow the susceptibility of the vaccinated people to coronavirus. So I don't make my mind whether it is true or not, but they try to make some research work on it. So then, okay, so we have discussed, I think, advantages of this vaccine. So, and then we come up to inactivated vaccine, and I can see that time is running very quickly. So there are so many types of inactivated vaccines, and I would like using influenza vaccines as an example to demonstrate how many different types of vaccines can be developed against one particular infectious agent. And influenza vaccines give us, or influenza virus gives us very good examples how we try with any types of vaccines to develop as better protection as possible. So here you can see in the right lower corner, so the infectious virus, that's how it appears, right? And you know that there's a hemagglutinin and neuraminidase spikes, right? And 8 segments inside the virion. So then this is infectious virus particle. Then what types of vaccines are most common right now? So by the way, in Russia quite often I've heard we may use live attenuated influenza vaccine. This is number one. Then we may use whole inactivated virus vaccine. So what does it mean? It means the whole virus had been taken, inactivated completely, no live viruses occur there, and then used together with all antigens that occur in the infectious virus particle, right? But it is killed. So if we compare the immunogenicity of infectious virus, live attenuated, and whole inactivated, of course, infectious virus, there's a highest immunogen, then live attenuated because it means it mimics the natural infection, and it is given intranasally usually to prepare the epithelium for the encountering the virus, and then the whole inactivated virus. The others are less immunogenic. So then we may have split inactivated vaccine. It is divided into pieces. Then we have subunit vaccine, and here it's very clear why do we call it subunit, because the only surface glycoproteins are isolated from the infectious virus, purified from the rest, and taken as an antigen for vaccination. See, there's nothing else but the subunits. So it is less immunogenic to compare with the split, whole, inactivated, and the rest, of course. So then, to make it more immunogenic, we can use so-called immunological adjuvants, but then maybe we'll touch it next time. Then we also may use vaccine that consist of synthetic peptides, but you can see that the different colors here. So these synthetically or artificially produced peptides mimic the important parts of viral glycoproteins of hemagglutinin and maybe neuraminidase. If we compare immunogenicity, the subunit vaccine is more or higher immunogenic to compare with the synthetic peptides. So this is the least immunogenic out of all this. Then I said in the beginning that sometimes we would like to induce the delivery system for vaccination for the target antigen. So sometimes we may produce or design in a vaccine virion-like particles with the sort of liposomes that are covered with the surface glycoproteins. And it reminds me, do you remember in hepatitis B virus infection in the patients we may find subvirional particles? Do you remember? Made up of surface hepatitis B surface antigen. That's something like this. So then we have the membrane, lipid membrane, with incorporated their viral glycoproteins. By the way, this is a quite good vaccine, and it is as immunogenic almost as the live attenuated vaccine. So, and it is delivered usually through inhalation or nasal drops, and it gives very good immunity. And finally, we have discussed a new one that is called DNA vaccine. Now I would like to miss all. Can I have some more minutes, right? So, and these are DNA vaccines. So the recombinant DNA approaches are very common, but that's a bit different. But then DNA vaccines. So they consist of naked DNA that code for the genes they contain genes that code for protective antigen. And that's how the DNA molecules appear under the scanning microscope. These are DNA inserted into the bacterial plasmid that can be used as a vector. So this is one of the promising type of vaccines, and again still we have a lot of modifications of these vaccines, and that's how we design the plasmids for vaccination. Usually they have the promoter, the regulatory genes at the beginning, and then additional sequences together with the direct proteins. And then we have the plasmid backbone delivers here we may insert adjuvants, for example, immunostimulatory sequences, they are called here right now, right? And then we may have a factor that could show us whether these some that can be expressed phenotypically somehow, for example, for bacterial plasmid that can be ampicillin antibiotic resistant genes, because easy to recognize these recipient bacteria, whether it is uptakes the plasmid or not, because it can grow on the medium with ampicillin, and if plasmid is not uptaken, bacteria cannot grow on ampicillin. So a lot of contacts can be done, and by the way, the plasmid DNA is supposed to be injected somehow, and that's working on the delivery system also. For example, there's a gene gun that is loaded with golden particles covered with the DNA molecule. So they make perforation of the muscle and skin cells and deliver the plasmid DNA directly into the muscle or skin cell. So that is the evaluation of the delivery systems. Okay, guys, we cover almost everything, right? Except for the calendars for vaccination. Take a look at them. So this is the, yeah, and the lecture will be also on the site of the university, delivered there, the site of the university, English version, microbiome department, teaching materials, right? So view it there and see the differences between the calendar for vaccination in the United States. There's a quick guide for parents, and this is quick guide for parents for 2020 for Russian medium. So those who are good in Russian may read it also. So we also may discuss it during the classes. So with this, I would like to finish and to thank you for coming, and then to invite you after 2 weeks for a lecture about coronavirus immunity and vaccine development. See you next time, guys. I hope quarantine will be finished soon. Goodbye.